Today we are going to be learning about a very important concept in surgery: surgical infections. We are going to study about common microbes involved, sources of infection, decisive period, presentation, and prevention of these infections. Let's get into it.
We begin with the core biological equation. An infection is not a random occurrence. It is a strict mathematical relationship. The risk of infection equals the inoculum size multiplied by the pathogen's virulence. This microbial attack force is the top half of our equation. It is then weighed against the bottom half. That bottom half represents the patient's own structural and systemic immune defenses.
Four distinct domains intersect to dictate this final outcome. First, we have the specific pathogen. Second, we have its origin source. Third, we have the decisive period of time during surgery. And finally, we have the host's natural defenses. We start with the microbial attack force. How we classify bacteria fundamentally dictates your clinical approach. We assess their gram stain, their physical morphology, and their oxygen requirements. By doing this, we can accurately predict their virulence mechanisms. This taxonomy is vital. It reveals their potential for biological synergy, and it determines their exact antibiotic susceptibility. Let us look specifically at gram-positive cocci. These pathogens primarily drive localized separation. This is the formation of pus. Streptococci form long chains. They actively destroy surrounding tissue. In contrast, staphylococci form tight clumps. They tend to cause heavily localized, walled-off infections. Understanding these specific pathogens is absolutely vital. Streptococcus pyogenes belongs to group A. It is highly pathogenic. It releases a tissue-destroying enzyme called streptokinase to cause cellulitis. Streptococcus faecalis belongs to group D. It relies on synergy to cause damage during bowel surgeries. Peptostreptococcus is an anaerobe. It triggers severe necrotizing fasciitis. Next, we have Staphylococcus aureus. This is a major driver of suppuration. It includes the notoriously difficult MRSA strains. Finally, Staphylococcus epidermis forms thick, protective biofilms. This presents a major threat in any surgery involving prosthetics. We now shift to the Clostridia family. These are gram-positive, obligate anaerobic bacilli. This means they cannot survive in the presence of oxygen. Instead, they produce highly resistant spores. These spores can lie dormant and then trigger rapid, severe surgical emergencies. Let us look closely at their exact pathogenic mechanisms. Clostridium perfringens releases potent proteases. This leads to rapid tissue destruction and gas gangrene. It produces a distinct crackling crepitus in the tissues. Clostridium tetani operates very differently. It releases an exotoxin called tetanospasmin. This exotoxin drives the severe motor spasms we know as tetanus. Meanwhile, Clostridium difficile causes pseudomembranous colitis. This most often happens when broad-spectrum antibiotics disrupt the patient's normal gut flora.
The intra-abdominal space creates a perfect environment for biological synergy. Consider a strict anaerobe like Bacteroides fragilis. It lives naturally and safely in the bowel. However, if it escapes, it acts in lethal synergy with aerobic gram-negative bacilli. Working together, they form severe intra-abdominal abscesses. This is a highly common and dangerous complication following colorectal or gynecological surgeries.
Several other key threats round out this microbial force. Escherichia coli drives urinary tract infections. It also participates heavily in bowel synergy. Klebsiella and Proteus are frequent culprits in catheter-related infections. Pseudomonas species are notoriously difficult to eradicate. They often colonize burns, tracheostomies, and intensive care units. Mycobacterium and Actinomyces act slowly. They form chronic, persistent fistula. Finally, fungi and cytomegalovirus act opportunistically. They specifically threaten patients who are already immunocompromised.
Now that we understand the specific pathogens, we must ask where they actually come from. Endogenous sources are internal. This refers to the normal flora already present on or inside the patient. This makes endogenous flora the most common modern source of surgical infection. Exogenous sources, conversely, are external vectors. They are acquired from outside the patient's body. These are the primary drivers of hospital-acquired infections.
Normal flora resides naturally in distinct anatomical zones on the human body. The nasopharynx carries Staphylococcus aureus. The pharynx houses Streptococcus. The lower gastrointestinal tract holds massive amounts of Bacteroides and E. coli. The vagina and oropharynx act as additional bacterial reservoirs. A surgical tissue breach changes this landscape instantly. For instance, if an inflamed appendix perforates, it is catastrophic. A massive inoculum of this endogenous bowel bacteria migrates directly into the sterile surgical site.
Exogenous vectors, however, are introduced by our own clinical environments. The operating theater itself may harbor inadequate air filtration or contaminated instruments. The surgical ward can suffer from poor hand-washing compliance. Hospital staff themselves may be asymptomatic nasal carriers of MRSA. Medical equipment, like vascular cannulae, invites dangerous biofilm contamination. We must also remain vigilant against viral vectors. Hepatitis and HIV transmit directly through blood-to-blood contact. Viruses like COVID-19 spread heavily through respiratory aerosols in the clinical space.
Following any tissue breach, we immediately enter a critical, decisive period. This is a narrow 4-hour window. During this exact time frame, bacterial growth races to establish a full infection. Simultaneously, the host defenses fight back to clear the contamination. If this 4-hour window closes before medical intervention occurs, prophylactic antibiotics become clinically ineffective. The battle is already lost.
This makes understanding a concept called MIC90 crucial. This stands for the minimum inhibitory concentration. It is the specific amount of antibiotic required directly in the local tissue to inhibit 90% of expected pathogens. The drug must reach these exact levels during that decisive 4-hour window. Therefore, prophylaxis is ideally administered at the very induction of anesthesia. This ensures maximal tissue levels are waiting the moment the first surgical incision is made.
We now shift focus to the denominator of our original equation. This is the host's own immune resistance. Certain systemic vulnerabilities will completely suppress the body's inflammatory response. Metabolic diseases like diabetes, uremia, and AIDS drastically reduce defense. Nutritional status matters greatly too. Both severe malnutrition and severe obesity weaken the host. Additionally, standard medical treatments like chemotherapy, radiotherapy, or steroids cause profound iatrogenic immune suppression.
These systemic vulnerabilities can trigger a catastrophic self-perpetuating loop of immune exhaustion. It typically begins with severe states of shock, overwhelming sepsis, or physical starvation. During these massive trauma events, normal gut enteral feeding is suspended. This suspension causes the host's internal defenses to collapse, and systemic failure quickly begins.
The biological cascade of gut translocation happens rapidly. First, the upper gastrointestinal tract becomes abnormally colonized by aerobic gram-negative bacilli. Next, these bacteria translocate directly across the gut wall. They move into the mesenteric lymph nodes. From there, lethal endotoxins flood into the systemic circulation. This triggers a deeply harmful systemic inflammatory response. Ultimately, this leads to multiple organ dysfunction syndrome and fatal organ failure,
Poor surgical technique inadvertently provides physical shields. These shields protect bacteria from circulating immune cells. Unopposed tissue layers create dead space for fluid to accumulate. Pooled blood forms hematomas. These act as perfect bacterial culture mediums. Devitalized ischemic tissue lacks blood flow entirely. Foreign materials like surgical sutures provide non-biological scaffolding for biofilms to grow. All these technical failures drastically lower the inoculum threshold required for an infection to take hold.
Synthesizing everything we have covered leaves us with this complete diagnostic matrix. Every single concept is deeply linked. We can map the specific pathogen strains. We can track their typical endogenous or exogenous reservoirs. We understand the surgical factors that enhance them and their hallmark clinical presentations. This matrix combines the pathogen, the source, the decisive window, and the host's vulnerability into one comprehensive, cohesive tool.
Now, we have to differentiate these by depth. It's crucial. They can be superficial, meaning they sit just under the skin, or they can be deep, reaching down into the musculofascial layers, that's the muscles and their connective tissues. In the worst cases, they can be severe organ space leaks, deep inside the abdominal cavity. We classify these infections as either major or minor. So what makes an SSI major? Well, a major SSI discharges a significant amount of pus. It often requires a whole second surgery just to drain it, and the patient becomes systemically ill. They'll show tachycardia, which is a fast heart rate, they'll have pyrexia or a fever, and their white blood cell count shoots up. Now, a minor SSI might also discharge infected fluid, but it doesn't cause those severe systemic signs, and it doesn't significantly delay the patient's recovery. When an infection isn't contained, it starts to spread. This fundamentally changes the game. It usually begins with a localized abscess, taking about 7 to 10 days to form after surgery. If that abscess is left undrained, it will physically track its way to the skin surface. This creates a chronic pathway, which we call a sinus or a fistula. The next stage is cellulitis. This is an invasive, rapidly spreading inflammation, very often caused by streptococci or staphylococci bacteria. It actually releases toxins right into the blood. That causes severe chills, fever, and rigors. If it keeps going, it escalates to lymphangitis. You'll actually see painful red streaks tracking right along the skin. These streaks follow the path of the lymph nodes, which also become painfully swollen and enlarged. These localized threats trigger a very precise biological response. We call it the inflammatory quintet. There are 5 distinct signs here: heat, redness, pain, swelling, and loss of function. In clinical terms, you'll hear these called calor, rubor, dolor, tumor, and functiolasa. These signs don't just happen by magic. They happen because a dense collection of dead white blood cells, specifically neutrophils, and bacterial toxins are literally gathering and packing tightly right under the skin. Let's make sure we clearly define a couple of important clinical terms here. First, suppurative. This simply means pus is present. So an abscess is a suppurative infection. On the flip side, we have non-suppurative. This means the inflammation is spreading rapidly through the tissues, but without a centralized collection of pus. Cellulitis is a perfect example of a non-suppurative infection. It's actually this spreading action that so often triggers those severe systemic chills and fevers we just talked about. If these spreading infections aren't stopped, they build into highly severe, life-threatening situations. Necrotizing fasciitis is one of the most dangerous. It spreads incredibly fast via the deep fascia, which is the connective tissue wrapping the muscles. It presents with this very characteristic dishwater-colored fluid seeping right from the wound. Doctors actually diagnose this using something called the finger test. It's exactly what it sounds like. When probed, the test reveals absolutely zero tissue resistance. It also shows a distinct lack of bleeding. And that confirms the terrifying reality that the underlying tissue is actively dying. Then we have fulminant infections. These act with sudden, devastating speed. Gas gangrene, for example, is caused by Clostridium perfringens. It causes rapid tissue death. You'll see a distinct sweet-smelling fluid or exudate. You'll also feel crepitus. That's a literal crackling sensation caused by gas trapped right under the skin. This leads to circulation collapse incredibly fast. Another one is tetanus. This is driven by the Clostridium tetani toxin, and it causes severe motor spasms. It usually starts locally as lockjaw in the face, but it quickly progresses to severe, generalized spasms across the whole body, which can culminate in total respiratory arrest. So what happens when a local breach totally escapes control? It overwhelms the entire human system in a very predictable sequence. It begins with bacteremia. That's simply when bacteria enter the bloodstream. This is a massive red flag, especially for patients with medical implants. From there, it escalates to systemic inflammatory response syndrome, or SIRS. This diagnosis happens if 2 of 4 vital thresholds are met: abnormal temperature, high heart rate, rapid breathing, or an abnormal white cell count. If you combine SIRS with a documented infection, it becomes sepsis. And ultimately, sepsis crashes into multiple organ dysfunction syndrome. It is a catastrophic cascade. The lungs fail, the cardiovascular system collapses into shock, and the kidneys and liver shut down entirely. Now, bacteria aren't our only enemy. We also have to consider viral implications in surgery. Untreated HIV presents a really high risk for opportunistic infections, like pneumocystis carinii. It also brings risks for neoplasms or tumors, such as Kaposi sarcoma. COVID-19 carries its own unique post-operative risks. Because it's a respiratory and vascular disease, the trauma of surgery can actually trigger acute respiratory distress syndrome. It can even cause fatal cytokine storms. That's an extreme immune response where the body essentially attacks its own tissues. This meticulous defense actually begins long before the first incision is ever made. We start by significantly reducing hospital stays. Why? To prevent colonization by highly resistant bugs like MRSA. We also actively screen patients for carriers. We practice relentless hand hygiene. But here's a critical detail. While alcohol gels neutralize most pathogens, they do not destroy Clostridium difficile spores. So soap and water are absolutely mandatory here. We also have to protect the patient's skin. Shaving must only happen immediately before surgery, right inside the operating theater. If you shave the night before, you create tiny, microscopic skin injuries that actively encourage bacterial growth. Finally, the surgical teams scrub their hands and nails comprehensively using heavy-duty antiseptic soaps like chlorhexidine. Next, our defense follows the patient right into the operating theater. And in here, environmental control is absolute. We use a laminar airflow currents. These are smooth, continuous streams of highly filtered air that physically push contaminants away from the surgical table. We prep the patient's skin with a single application of concentrated alcohol-based antiseptic. That alone reduces bacterial counts by over 95%. Once the procedure begins, surgeons employ incredibly gentle tissue manipulation. They deliberately avoid creating empty dead spaces in the tissue. They carefully remove any devitalized or dead tissue, and they prevent blood clots, known as hematomas. These physical errors are basically prime real estate for infections to breed. We also keep the patient warm to avoid hypothermia and provide extra oxygen during their recovery. When it comes to medication, timing is literally everything. The most crucial decision is exactly when to administer prophylactic antibiotics. They must be given precisely at the induction of anesthesia. We do this to ensure that the absolute maximum antibiotic concentration in the tissues happens exactly at the moment the surgical blade first breaches the skin. Now, a single antibiotic dose is the standard protocol for most surgeries. But medicine is dynamic, so we must adapt to the environment. We have to redose the patient if the operation exceeds 4 hours, if there's excessive blood loss, or if we encounter unexpected contamination. In cases of extremely heavy contamination, we might even alter how we close the wound entirely. We might leave the skin open to granulate. That means allowing it to heal safely from the bottom up before closing it later, or we might leave it open entirely to just heal naturally over time. Furthermore, patients with heart valve disease or medical implants require antibiotics even for minor dental procedures. This is just to prevent transient bacteria in the blood from colonizing those vulnerable areas. Finally, our defense continues out on the recovery ward. Here, we rely heavily on universal precautions. Medical teams use double gloving, waterproof gowns, and full face masks as a physical shield against bloodborne viruses like HIV and hepatitis. They wash their hands strictly between every single patient contact, no exceptions. Gloves must be worn when touching any wound to stop environmental transmission. And to block COVID-19, hospitals enforce preoperative cocooning. This requires strict isolation for 10 to 14 days. They also execute mandatory swab testing precisely 2 to 3 days before any elective procedures.